Good morning. Good morning. Good morning. Good morning. Thank you so much for spending a little bit of time with us on this beautiful Thursday morning. If you wouldn't mind letting us know who you are in the chat, that's our favorite. Who are you? What do you do? Are you a clinician? Are you a navigator? And where are you from? We often get people in our training from all over the state of California, but sometimes from way far outside. So we just want to know who you are. Good morning. Hi. So let us know who you are, where you're zooming in from. And with no further ado, we're just going to go ahead and jump in and get started. We have got a jam-packed half an hour to get through. So I am Alicia Gonzalez. I am the clinical training lead and an implementation leader here for the California Bridge program. I'm also an emergency physician. And the goal of this training is to talk about Bupe beyond the X-waiver. We finally, big news, got rid of that silly X-waiver that was in the way and really was just kind of a stigma-driven piece of legislation that doesn't exist anymore, which is wonderful. But we want to get back to those basics, talking about MAT as a standard of care for patients with substance use disorder, specifically for opioid use disorder. So this is no longer like a newfangled idea coming down the pipeline. This is really the standard of care. And we want everybody, every clinician in California to feel comfortable using buprenorphine to treat their patients with opioid use disorder. So the California Bridge program is a part of the Public Health Institute. That's our copyright and our funding source. We don't have any financial disclosures. If and when I say the word Suboxone to refer to buprenorphine, I'm not doing it because anybody's paying us. I'm saying that because our patients say that. So if we use brand names, please know that it is not on purpose. We're not promoting any specific branded drugs. If you are new to us, welcome to the California Bridge family. Our goal is to provide 24/7 access to high quality medication-based, evidence-based treatment for substance use disorders in every California hospital by 2025. We are getting close. We are at like 280 hospitals participating in our program these days. So welcome. And why do we want to do that? Because opioids are still killing Americans and they're killing people all around the world. But for us here in the US, a ton of people, 107,000 people died from drug overdose in 2021. That number actually climbed in 2022. It's a higher number now, which is crazy despite all of our efforts. And if you're somebody out there who thought, well, hey, at my hospital, and in my practice, we decreased how many opioids we are prescribing. We're really doing our part of opioid stewardship. First of all, bravo, good for you. We want to use alternatives to opioids in treating acute pain, especially if it's mild or moderate pain or exacerbations of pain. But this graph shows you that that's not enough. The purple bar on the bottom is shrinking, you'll notice, over time because we have done a ton of work to decrease those prescriptions. Great, awesome. But the blue bar in the same period of time keeps rising. The number of deaths from opioid overdose keeps rising. And that is because fentanyl. Illicit fentanyl is all over the place, and there are really strong opioids out there that are still causing our patients to die that have nothing to do with how much we are prescribing or not prescribing opioids. So that's a part of the problem, but we got to get ourselves focused on treatment because addiction is not a moral failing. The days of being on a soapbox and having a lot of stigma towards patients who use drugs are over. We know that like 30% of Americans use substances. So we're talking about a third of the population, all right? We need to treat them the way that we treat people with diabetes, who maybe sometimes make poor choices and eat donuts. And we need to treat them like patients with asthma who have exacerbations and come in seeking, treatment with albuterol. They're not albuterol seeking. They just need stabilization on their chronic disease. Same with patients who come to us in withdrawal, right? They're not drug seeking. They're not addicts or junkies. They're people who have a substance use issue and are here waiting for us to help them. And we have great evidence-based care that we can use to treat those patients. And that should be the focus. So in the California Bridge model, we have three main pillars. The first is that low barrier access to treatment. And we're going to spend the rest of today focusing on that. Second, though, ongoing connection to community support systems and ongoing outpatient care. That is the role of our navigators. I don't know how many of my navigators are here today. Holler to any of you. So your hospital, if you're participating in California Bridge, should have a person who is dedicated to helping our patients. We stabilize in the ED, but we want to help them connect to that ongoing care in the community. That's a really important part of it. And then maybe if they, have another crisis, they relapse or they're off their medication, it's not working, they come back to us. Like with any other chronic disease, we're there for the acute issue, the stabilization, but we want to make sure that ongoing outpatient care happens. And finally, culture of harm reduction, which is really two pieces. One of them is getting rid of the stigma that surrounds substance use treatment. And then the other is actual physical tools for our patients who are going to use substances to be able to stay healthy and live well and not die from using those substances. So it's a combination of all those three things. And we are going to focus on the quick start buprenorphine for patients with opioid use disorder specifically. Hopefully this is not the first time you've heard some of this material. Hearing it multiple times helps us to make sure we memorize it and can speak to it better. But buprenorphine saves lives. We know that patients who are using opioids, who are not in treatment, like the blue bar here, that their risk of death is 6 times higher than that of the average person. So if my risk of death as the general population is 1.0, then somebody who is using opioids is going to be 6 times more likely to die over the next 5 years than I am. But if that person gets into treatment with methadone or buprenorphine, their odds of death approach that of the general population. So only 1.8 times, less than 2 times more likely to die. Huge reduction in mortality, significant life savings. So that's where this some of this evidence comes from. We don't just want to start people on treatment, we want to save their life. And that's what starting them on treatment does. And for us in the emergency department, what we care about is the timing. Why is this an emergency medicine problem, right? Not everything should be, but this is. Just like a TIA or high-risk chest pain, when patients come to the ED after an overdose, they are in a particularly high-risk, vulnerable moment that makes their presentation an emergency. This study looked at patients who came in after an opioid overdose, having to require naloxone for reversal, either naloxone from EMS or naloxone there in the ED. And what they found is that in general, that population had a high risk of death over the next year, just in general, all comers, which kind of makes sense, right? Like they just died and we resuscitated them, brought them back to life, which is great, but their risk of death, again, is kind of high. Of that group, though, 20% of them died in the first month. And of that group, 22% of them died in the first 2 days. So this big bar on the graph, the first one, farthest over to the left, shows you that their highest risk of death after overdose is in the next 48 hours, which means patients who come to the emergency department after an overdose are at an extremely, extremely vulnerable place in their life where their risk of death over the next 2 days is very high. It is a critical time for us to intervene and teach them harm reduction and get them into treatment to literally save their life. Again, the same way that we take a TIA patient and we worry about conversion to stroke, or a high-risk chest patient, unstable angina, and we worry about their conversion into a full-blown heart attack. Same thing here. Don't worry, not advocating that we admit those patients, but advocating that we take them seriously and that we realize the crucial moment that we have them at in our ED that we can make a difference. There are other medications for opioid use disorder, and this presentation is not to knock those medicines. Some patients should be on methadone and they're doing well on methadone. Leave them on methadone. We don't want to like switch everyone to buprenorphine. But for us in the emergency department and the acute hospital setting, we like buprenorphine. And we talk about bup as a plain medicine. That's the functional medicine. Bup naloxone combo is often called Suboxone, the most common brand name. Our patients usually call it Suboxone. And that medication, the naloxone is inert. It doesn't do anything as long as you take the medication correctly. But if you were to say melt it down, snort it, inject it, try to abuse that medication or use it incorrectly, then the naloxone kicks in to make the buprenorphine non-functional. So if you're taking it correctly, which is sublingual under the tongue or in the cheek to melt, either way they dissolve in the mouth. If you take it that way, the naloxone doesn't even get absorbed into your body. So that's the combo. But the buprenorphine medication we love because it's only a partial agonist. So whereas methadone is a full agonist, or drugs that we take like fentanyl or heroin, right? Full agonist on that that opioid receptor. Buprenorphine is only a partial agonist. So it has a respiratory depression ceiling. When you take more of it, you're not going to stop breathing, which is wonderful. You also don't get that same altered sensorium, the altered mental status, altered mental state that you get when you take a full agonist opioid. So by taking buprenorphine, people can still drive a car. They can have a job. They can not worry about necessarily overdosing if they require really high doses because of their use pattern. This medication has a really, really high affinity for that mu receptor. So if you take any other opioid, buprenorphine will win. It will knock off fentanyl. It will knock off methadone. It will occupy that space. What's nice about this is that if the patient is taking buprenorphine, it's in their system, and let's say that they relapse, they take fentanyl, they use heroin. If they do that, The buprenorphine holds on tighter. So it actually provides some airway protection in the sense that fentanyl, right, is a strong respiratory depressant at high doses. Buprenorphine is not. So by having some of those receptors covered with buprenorphine, it can actually help to protect people from overdosing if and when they do relapse, which is wonderful. It lasts in the body for about 24 to 36 hours. So it's long acting. Most patients can end up on once a day dosing. They can do twice a day dosing just as they get used to it, but oftentimes it ends up being a once a day medication, and they can have a prescription. So you're talking about seeing your doctor once every month or once every couple months instead of going to a methadone clinic every single day. So again, methadone, great medication, but these are some of the reasons that we like buprenorphine, and it works better for us in this setting. The other study that is really important for you to know about, Dr. Gil D'Onofrio over on the East Coast is sort of a pioneer in this work. And what their team did was they looked at patients who came in opioid withdrawal. All those patients got connected to ongoing care, really, really good follow-up with an MAT provider, a medication for addiction treatment outpatient provider. But half the patients were randomized to start buprenorphine immediately right there in the ED, whereas the other half were just connected to really close follow-up and then started on medication. What they found is that one difference, starting the medication in the emergency department, doubled the likelihood that that person would stay in treatment at 6 months. And so since I told you already, there's a huge mortality reduction from being on medication for addiction treatment for opioid use disorder, what this means is that at 6 months, you have doubled the likelihood of saving that person's life, right? You have significantly decreased their mortality risk at 6 months. So more evidence. And if you're a number needed to treat kind of person, what we're saying is 2. It only takes 2 people to keep somebody in treatment at 6 months, which is a life saved. So big deal, really, really good evidence. This is the standard of care. It is no longer a new exciting thing. And we know that it works, which is the good news, because we know that opioids are such a terrible thing in our communities. We love having this as a tool that makes it better. So I do see some questions in the chat and some comments. We will get to those at the end. So I just want to make sure that we get through all of these so that everybody who came here for the meat of this gets to see it. This is the California Bridge Quick Start Guide. This is the #1 most important thing on our website. How do you start a patient in withdrawal on buprenorphine when they're right in front of you, either in the hospital, same process for the hospital setting, in the clinic, if this is what you're going to do, or in the emergency department. You can see this on our website at cabridge.org/resources. So we're going to walk through it. First, patient needs to be in withdrawal and make sure there's no contraindications. So what does that look like? If you're not sure, you can use the clinical opioid withdrawal scale to help you. It's just a scoring system that helps remind you of what the symptoms of withdrawal look like. But if you are a trained clinician, you don't need cows. You don't need it. You are able to just say, hey, that looks like moderate to severe withdrawal for me. I'm good starting the patient on this medication now. But if you're not as comfortable, you can use cows to support you. And you want a score of 8 or higher with at least 1 or 2 objective findings. We'll talk about that in a second. You want to make sure the person's obviously not like altered or acutely intoxicated with another substance, right? If somebody has really a high alcohol level, it's not the right time for us to be giving them buprenorphine as well. This is like the day they come in shouldn't be the day they also were in a multi-system trauma or they're in acute renal failure, right? They have a huge medical emergency, probably not the day for us to focus starting on buprenorphine. You don't want to give it to a patient who has taken methadone in the past 72 hours. We mentioned, right, that buprenorphine, it has a higher affinity, would knock methadone off that receptor and precipitate withdrawal. So we don't want to do that. 72 hours from methadone. Key piece, you do not have to screen for the methadone though. Just asking patients in general and being clear about why you're asking them is good enough. So verbally screen the patient for any methadone use in the past couple of days. And then this is also not for somebody who is an occasional opioid user. This is really for somebody who uses opioids every day and is has physical dependence on the opioids to feel normal. And now they are going through active withdrawal in front of you. So if all those things are true, and especially if they use fentanyl, please make sure we're going for a score of 8 or higher, moderate to severe withdrawal, and that you do see objective findings, dilated pupils, the goose flesh, goose bumpy skin. Are they vomiting or having diarrhea? They went to the bathroom 8 times while they were waiting for you. Is their heart rate fast? Are they tachycardic? Are they yawning? Are they clearly agitated, like pacing around the room? Do they have the runny nose and the watery, itchy eyes? So if that is what it looks like, any of those objective findings is there, you are good to start. You are going to give that patient 8 to 16 milligrams of buprenorphine. Remember, sublingual dissolvable dose, so nothing oral, for about 15 minutes after that. It's kind of like when you give an ondansetron ODT tablet for nausea and vomiting. You can't follow it with water. It does not get absorbed in the stomach the same way. So let it fully dissolve in the mouth. What I will say about this is that if the patient uses fentanyl as a self-disclosed, like, oh, fentanyl is my drug of choice, just start with 16. And if they use a very high amount of fentanyl, and if you're not sure what that means, ask them, would you say that you use a lot of fentanyl or a small amount of fentanyl? If they say, I use a lot of fentanyl, you could go straight to 32. Don't be afraid to start at a higher dose. The way more dangerous thing is to give a small dose, which isn't going to do anything. So no 2 or 4 milligram doses, at least 8. If they use fentanyl, please start with 16 milligrams. Don't be afraid to do that. And if they are a heavier use pattern type patient, go ahead and think about going maybe even to 32 milligrams to start. Again, screening for methadone. And then think about things like, I said that buprenorphine is not going to cause respiratory arrest all by itself, but in combination with other agents that cause respiratory depression, you could see that. So the patient also uses benzodiazepines, Ativan or Xanax. If they use alcohol, if they take, muscle relaxers or other medications that can depress the respiratory system, it does not mean that you cannot start buprenorphine, but maybe that's not the best patient to give bupe in the lobby, right? Maybe that patient should be on a pulse ox in a room just so we can watch them and make sure that it's safe. Still start, but just being a little bit more vigilant about that. Again, typically 8 milligrams might require higher doses. The key point of this slide is don't be afraid of those higher doses. We get a lot of clinicians who are nervous about it. Don't be nervous about it. 16 to 32 milligrams up front. We have studied this. It is safe. Don't be afraid to start with a really good dose. It might take you more than one dose to help this patient feel all the way better. So you give that first dose, you want to wait about 45 minutes to an hour and reassess your patient. And if they are getting better at all, give another dose. So even if the person's like, wow, that 16 saved my life, I feel completely normal, finish it, finish the job, give them another dose of 8 to 16 milligrams. Most patients are going to leave the ED with at least 16, if not 32 milligrams in their system. When they go home, they may not need as high of a dose as they needed in the emergency department, but that first resuscitation day, you're going to want to give them a couple of rounds to make them feel all the way out of withdrawal. And especially with patients who use fentanyl, this might take several doses and it might take some time. If the patient did not get better at all, take a step back, because plain opioid use should get better with buprenorphine. So are you missing something? COVID, sepsis, DKA, is there another substance withdrawal happening? Are they in alcohol withdrawal? Are they coming down off methamphetamines? Is there something else that you're missing? That said, the most common reason that patients don't get better is actually that we didn't give enough buprenorphine. So if the patient has a high use pattern, for example, they use, say, like a gram of fentanyl a day, and you give 8 milligrams of buprenorphine, they're probably not going to get better right away. They're going to need a lot more buprenorphine to feel all the way better. So don't be afraid of higher doses. Don't be afraid of repeating those doses, and make sure that we're not under-treating their withdrawal, which is not the same as precipitated withdrawal. I know, I said it, the nasty P word. But I want to clarify the difference between what those two things are, because we get a lot of clinicians that say, I feel like I'm constantly precipitating withdrawal. Undertreated withdrawal is far more common than precipitated withdrawal. So when you give bupe and the patient seems to just be getting sicker and sicker, that's usually undertreated withdrawal, which is that the buprenorphine doses are not meeting the patient's needs to be able to treat their withdrawal all the way. Patients can store fentanyl in their adipose tissue, so it can take longer for them to go into full-blown withdrawal. That fentanyl stays in their system for longer. And so what we see is just they need higher doses. So don't be afraid to start high and repeat those doses frequently. That is not the same thing as precipitated withdrawal, which is that the patient has full agonist opioid actively in their system, and you knocked off that full agonist to replace it with buprenorphine, which takes them from full agonism to partial agonism, which is precipitating withdrawal. When we looked at thousands of patients, which is still an unpublished NIDA study, but thousands of patients that we started on buprenorphine, most of them, more than 2/3 of them, self-disclosed as that fentanyl was their drug of choice. Only fewer than 1% of those patients had true precipitated withdrawal. So please don't be afraid of it. It doesn't actually happen that often. More, it's undertreated withdrawal. And P.S., if you're still concerned about it, don't be. We do it all the time on purpose. We give patients naloxone to wake them up from overdose. That is precipitating withdrawal. And I want you to think about what that looks like. Somebody is literally unconscious. We give that medicine and bam, they are awake. They are sweaty. They're often really mad at you because that's not what they were going for. Sometimes they elope from the emergency department. It's just like a cute, fast, sudden worsening in withdrawal symptoms. That's not the same as, hey, buddy, it's been an hour and I'm still vomiting, and actually I'm kind of getting sicker over here. Not the same thing as true, sudden, precipitated withdrawal caused by buprenorphine. So think about that as being a little bit of a difference. And even if you do precipitate withdrawal, I really don't want you to be afraid of it. I think the fear comes from the patients obviously have a very rough experience. No one wants to feel that. And patients talk to each other. They say, you get sick off bupe. It made me really sick. You could precipitate withdrawal. Patients know about this. And obviously we have heard over and over at every hospital, it feels like providers are uncomfortable sometimes starting buprenorphine because they don't want to have a bad interaction with their patient. Who would? And so part of the way that we combat that is by talking upfront with our patients to normalize the withdrawal experience a little bit. So for example, you might tell them, hey, it's going to take some time for this medication to work. It might take me multiple rounds. You might feel a little bit sicker as we go, but I'm here for you. And I'm going to help you no matter what happens. I'm going to be back in here 4 times today. We're going to get through this together. You might tell them like, hey, I know withdrawal totally stinks. It's painful and awful. And I know that. And I can't make that go away like this. I wish I could, but I can't. But instead, I'm going to make this the best withdrawal experience of your life. You are going to have support and medications from me to make this the best withdrawal that you could possibly experience. I just need a little bit of time. And then ask patients outright, have you ever tried buprenorphine before? Do you know anybody who has? And if they say yes, talk about precipitated withdrawal up front. Be honest about the risk, right? Starting bupe, doing MAT, it's a procedure. And like any procedure, it's important to have the patient understand what you're doing, why you're doing it, and what the risks are, and what you're going to do if those risks like precipitated withdrawal do occur. And that's okay. A lot of it is just communication. And having done this many times, this doesn't take that long. I can get through a bupe consent in like 2 minutes. It's not a big deal. Patients just want to hear that you're there for them. And then if you do it, if it does happen, keep calm and give buprenorphine. And then give more buprenorphine. The key way out of it is just to give enough bupe to saturate enough receptors that they actually come out of the withdrawal. So that's really the mainstay of treatment. But we do have a couple of other recommendations, which is you're going to give more bupe, at least 16 to 32 milligrams extra right out of the gates. But you're going to also consider giving a dose of a benzodiazepine because that's a very anxiety-provoking moment to be suddenly in worsening withdrawal. I would also say if you have a patient where you're giving multiple doses of buprenorphine and they just have maybe a very heavy use pattern, don't be afraid to give a single dose of a benzodiazepine up front. Maybe a 2 oral milligrams of Ativan is a common choice, just because it is very like anxiety-provoking to go through this experience in general. So you can give that. Don't forget about things like clonidine or Haldol or, other normal medications you would use for the symptoms like nausea and vomit. You can give, Zofran, Reglan, Compazine, whatever your favorite antiemetic is. Don't forget about all those medications. And then there are a lot of experts in the field who are using subdissociative ketamine as a way to help patients get through this experience. And then worst case scenario, you throw in the kitchen sink at this patient, you've given a ton of buprenorphine. And by a ton, I mean like, not just 16 milligrams, right? We're getting like up into the 50s and you're dosing. You've done all of that. You can always give a dose of fentanyl and admit the patient for like a longer course of getting them onto treatment. So that's sort of what that looks like. We have this on the Quick Start Guide. Don't be afraid of it. I mentioned that some patients are going to need higher doses up front. Maybe you went to 50 something milligrams to get that patient out of withdrawal. Most patients will still go home on about 16 to 32 milligrams daily. So that can be 16 once a day. It could be 16 twice a day. It could be 8 once or twice a day. It could be 16 once a day. So once or twice a day to get them between 16 and 32 milligrams. That's a common maintenance dose. We recommend that you give enough for that patient to be on that treatment at least 14 days. There are not very many places in California where a patient can get into a clinic faster than 14 days. I would say, though, please work with your navigator. If patients take a month to get into treatment, give them the full month of treatment. Don't be afraid of that. Don't be afraid of things like diversion. Remember that buying fentanyl on the street is cheaper than buying buprenorphine. People who want to be high wouldn't pick a buprenorphine. It doesn't make you feel high the way fentanyl makes you feel high. So they're going to pick those full agonists. But there are people who divert buprenorphine. That's true. It does happen. The majority of the time when it happens in the community, it's actually people who are trying to get out of withdrawal. They'll buy buprenorphine to get out of their withdrawal, self-treatment, which is one reason we want their treatment from us to be easier to access. So they're not, trying to buy it illegally from somebody else. And the big news here, we used to talk about the X-waiver. There is no X-waiver. If you have an active DEA license that includes Schedule III medications, so if you can prescribe hydrocodone or oxycodone, you too can prescribe buprenorphine for opioid use disorder right now with no special paperwork, no license. That is gone. So please, don't be afraid to do this. Give patients enough. These like 3-day prescriptions are not helpful. What we're doing is encouraging people to return to use when they run out of their medicine and couldn't get into follow-up. And now they're back in withdrawal again, right? That increases their risk of relapse or of return to use. We also want to send everybody home with naloxone. We'll talk about that in a minute, but it's just a safe thing to do for all of our patients. I'm going to say it one more time. We did it. We got rid of the X-waiver. So even if you're like, oh, I still have one from before. No, you actually don't. There just isn't even one. They erased them. They don't exist. They took it away and sent you a new DEA without this number on it. It is gone. So thanks to everybody who helped with the advocacy on this, but this is a real thing. It is already active. Pharmacies are aware of it. No more X-waiver. Please don't let that be the thing that keeps you from doing it. And if you are in the middle of trying to treat a patient and you need help, you can call California Poison Control or this substance use line. Take a picture of this slide. It's really helpful. We also have these numbers on our website. So to recap, patient is in withdrawal. It's uncomplicated. There's not like a bunch of other stuff going on. They're not medically sick, etc. You're going to give 8 to 16 milligrams of buprenorphine. Don't be afraid for patients with heavier use pattern to start with 16 to 32 milligrams. You're going to wait an hour. If they're getting better, give them more medication. Get everybody to at least 16 milligrams, maybe even 32 milligrams, no matter what, before they go home. If they didn't get better, are you under treating the withdrawal or are you missing something else? Take a step back, don't forget. And when they go home, no matter how much it took you to get them stabilized in the ED, most patients will go home with 8 or 16 twice a day as their maintenance dose. Give them enough that they're going to make it to that clinic appointment and maybe even miss the first one. Give them enough medication to get them to that ongoing outpatient care. You don't need an X-waiver. If the patient wants to start treatment, but they're not in withdrawal right now, you can write a self-start prescription, okay? So if you're actually still uncomfortable, guess what? Patients don't even need you. That's how safe this is. They can do it without you. So we have this handout on our website. Feel free to print it. You can send patients home. It basically mimics the hospital start. The patient waits till they're in withdrawal, starts the medicine, titrates up, et cetera. And evidence shows this is very safe and patients can do it. So it's a great option for patients. Maybe they're here with an abscess, but they're not yet in withdrawal, but you had the opportunity to talk about it. Send them home with that self-start prescription. Big question we get, what if my patient is pregnant? First thing I want everyone to remember, there are more pregnancy-related deaths from overdose than from hemorrhage or preeclampsia. So we talk so much about things like preeclampsia. We have all these gold standard treatment things that we're always watching for. More patients will die from overdose during pregnancy than that, which is a big deal. It definitely affects our patients. And MAT in general, both methadone and buprenorphine, is safe in pregnancy and breastfeeding and is formally recommended by the American College of Obstetrics and Gynecology from ACOG. So they're on board with it. We're on board with it. The evidence supports it. It's completely safe. Buprenorphine, buprenoloxone, Suboxone, the combo, and methadone are all safe, again, in pregnancy and in breastfeeding. It does reduce the risk of neonatal abstinence syndrome to use buprenorphine. And if you're curious, like the treatment for the baby is mostly just like consoling and feeding through. And they do better on buprenorphine than methadone. They have less instances of neonatal abstinence syndrome. And pregnancy starts mirror non-pregnant starts. So everything that I just went over is exactly the same. Don't change anything. Don't decrease your doses. Don't worry about it. It's all the exact same thing. So if you have that quick start guide on lock, you still have it on lock for a pregnant patient. And the patient does not have to get fetal monitoring. They don't have to come into the hospital to start buprenorphine. You can still do it in the ED, or they can do a self-start safely. Patients in their 3rd trimester may need higher doses just because they have an increased body mass. But otherwise, that's kind of the only difference. Earlier in pregnancy, it's absolutely the same. And we do not stop buprenorphine during labor. And we do not stop buprenorphine for patients who are in pain. So what do I do if a patient is on bupe and now they're in pain? Don't stop the bupe, okay? You can take their overall 24-hour dosing and divide it into a couple of smaller doses. So let's say somebody's on 32 milligrams a day. They can go to 4 times 8 milligrams a day doses. They can take 8 milligrams every 6 hours instead. Their withdrawal treatment for buprenorphine is long. We talked about that. The half-life is long, but the acute pain management of buprenorphine rises and falls a little bit faster. So that helps them to get that pain medication dosing a little bit more frequently. After you've divided it up, you can also go up on those doses. So maybe you went to 8 milligrams 4 times a day. You could change it to 16 milligrams 4 times a day. You want to remember all the alternative to opioid treatments that are out there. I won't get into them. We have a whole separate lecture on that, but don't forget to add alternative to opioids. And at some point, if it's really severe, let's say it's a trauma, et cetera, you can add full agonist opioids on top of it, but don't stop the buprenorphine. Keep the buprenorphine in their system. Adding full agonists on top of that's not going to cause withdrawal, but giving a bunch of fentanyl and then re-adding buprenorphine will cause withdrawal. So just keep the bupe in their system, keep it active and scheduled, and don't be afraid or hesitate to treat the pain. We have a full protocol that goes over all of this on our website. I want to say less than 1 minute about harm reduction, just to make sure there are things that you are aware of. First, fentanyl test strips. These are a little bit more complicated than you might think. We have a full FAQ on how to use them at the California Bridge website, but please tell patients about them. They don't work well for high dose, like high concentration methamphetamines. You get a lot of false negatives there. So please, though, make sure that you know this is there. Patients might ask about it. We have a great handout you can give them. We want patients to go home with naloxone in their hands, not like a prescription, okay? Only 1 to 3% of patients will fill that prescription. So instead, state of California will give you a bunch of naloxone for free to hand out, unlabeled, anonymous, super, super simple. If you want more info on that, reach out to us. We can help you get that set up at your hospital. But everybody goes home with naloxone. It's like the toothbrush from the dentist, man. Send everybody home with naloxone. Make sure your patients know not to use alone, right? There's clandestine, weird stuff, xylazine, fentanyl, et cetera, in a lot of drugs out there. We don't want people to overdose and die because nobody was with them. There's an anonymous hotline they can call where all you really give is your location. And then if you were to say overdose and nobody's there with you, this hotline will send EMS to respond to where you are, which is a wonderful service. That's a national hotline. And then make sure we talk to patients about safe injection practices. If possible, no injecting, right? Smoking is safer than injecting, especially when we talk about things like HIV and hepatitis and all the stuff that comes from using needles and syringes. Make sure they know how to clean it, to not reuse their supplies, to use sterile or new equipment, not to reuse and share equipment, and make sure you have information for your local syringe exchange program and how to get testing through your public health department so they can monitor for HIV and Hep C. If you forget everything that I just said, you can find all of it on the California Bridge website. Please come to our website, cabridge.org. And you can also reach out to us, info@cabridge.org. That's a real human being that answers those emails. So feel free to email us anytime, info@cabridge.org, and we'll get back to you and route you to the right place. So that is our time. Anybody who has to go, please feel free to go. I'm going to scroll up and see all the questions. There's so many questions in here that I missed while we were going, and I really appreciate all of you being here. So I will stay and answer these questions. The rest of you, have a great day. All right, let's see. Yes, oh my gosh. So anybody who needs these slides, you're like a champion, you want to share these slides at your own site? Yes, we have that available to you. I know Elizabeth, our awesome program manager, Elizabeth Keating, put the link in the chat for you. But if you can't find it or it's later, info@cabridge.org, email us. We will get slides like this in your hot little hands so you don't have to make them on your own. Yeah, so a little bit of dispelling. It does not, the combination tablet naloxone does not counteract the buprenorphine if you take it sublingually and correctly. So just so that you know, that's a thing that all of our experts and the founding members of California Bridge, that's a teaching that we always offer. We mainly talk about that because patients get concerned, like, I don't want to take it because the Narcan is going to make me sick. And so that's the piece that's the education is, no, it doesn't actually get fully absorbed into your system. It's not like taking Narcan. You're not taking Narcan, you're taking the buprenorphine. Some patients, though, do have a history of getting GI upset, of stomach upset with the combo tablet, and they may tell you that, like, actually, it made my stomach hurt. I felt kind of nauseous. That's real. And in those patients, we recommend just switching to the plain buprenorphine without naloxone in it. But the point of that piece is that the naloxone is inert in the sense that it does not do anything. It doesn't counteract the effects of the buprenorphine. All right, let's see what else. Oh, Ohio. Go Ohio. You guys have so much hard work ahead of you, just like we do, but we appreciate you being here. And all of our stuff is agnostic, by the way. Everything I mentioned, not California specific. Do this in Canada. The only difference would just be the naloxone distribution program that I mentioned is specific to California. All the rest of it, though, any state, any country, the medicine is the same. So thanks, Barbara, for being here. All right, let's see what else. How will patients show signs of withdrawal, and how do you look for a patient in withdrawal? So that's a great question. If you're not as comfortable with knowing what withdrawal looks like, feel free to use that COWS, right? So what you know what the symptoms are and you're watching for it. I would say that I've gotten to a point where patients that I see who are sweaty and tachycardic and seem irritable, I almost always ask about drug use. And then I explain why. I'll just say something like, I know you're feeling really sick. Some withdrawal patterns can cause these kinds of symptoms. So I just wanted to also check, do you ever use drugs? Do you ever use pills or fentanyl or anything like that? Just because that could be the cause of it. And patients who do not use drugs will be like, no. And then oftentimes patients will, if you say it that way in a kind and open way, they'll tell you. But it looks a lot like a viral illness. Unfortunately, it looks like alcohol withdrawal. It looks like a lot of things. But if you're not comfortable, use that COWS until you feel more comfortable. What advice can you give for providers still giving 2 or 4 milligrams? Don't do it. It's dangerous. It's like, it's not even the same. I used to joke that it's giving pixie dust, like you're not doing anything. Now I would actually say it's dangerous. You're risking making the patient sicker by giving doses that are inadequate. It's not the right treatment for your patient, and we really shouldn't be doing that anymore. So providers who are still using 2 and 4 milligrams, you need to stop. That's bad medicine. Please don't do it. We have significantly proven that we don't need to do that, and you could make the patient be sicker instead of better. Pediatric and youth patients. Yes, we do have some resources. I think Elizabeth posted them for you in here, but they are on our website. We have some youth-oriented stuff. People ask a lot of questions about, like legal and consent and all that stuff. So we do have resources that describe that. There also is some great stuff out there from the KP, the Kaiser Family Foundation. That's what it is. They have some really great resources about the ethics and like the legal description of what you can do and cannot do with and without consent from a parent. They have some great documents out there. So we have those resources. We can get those too. info@cabridge.org if you ever can't remember where these links were from. Are there peer-reviewed studies that support 24 to 32 as the first day of treatment? I get a lot of resistance. Yeah, we actually, California Bridge, our PIs published a study showing in Annals of Emergency Medicine, I want to say last year, that showed that starting with high dose, they used to call it macro dosing versus micro dosing, right? That macro dosing was safe and effective. If you email us at info@cabridge.org, we can send you those references if your doctors or your providers need to see those for more comfort. No problem. We do have evidence of that. Yes, the recording will be available. Let's see what else. Yes, our clinical resources are the best in the country. Please feel free to go check any of them out. And yeah, I got that 2 to 4 milligram one. Pregnant patients to be addressed. Oh my goodness. Peds, that's a really hard one. If you're struggling with youth stuff, reach out to us. We have some experts who can give you some advice, but it is tough. If you're struggling to find outpatient follow-up for youth, you are not alone. That is a very hard thing for us in the state in general, in the country in general. Okay, that looks like all of the main. Oh, the max dose is not 24 milligrams. You can give higher doses. So there are patients that have been on doses as high as in the 60s. You mentioned here 64, and the answer is yes. You could be on 64 per day. So technically, the therapeutic ceiling for buprenorphine is somewhere, I want to say it was in the 50s, like 52, 54 milligrams, somewhere in there. However, remember that when you have opioid dependence, that your physiology does change. And so patients' bodies are all going to be a little bit different. Our experts who work in what we call our clinical centers of excellence, a network of hospitals who've been doing this work in California for a long time, and they frequently treat patients in withdrawal. All of them have given higher doses than that. They have all given into the 60s. Some have given higher. And so just realizing there is a ceiling effect on the respiratory depression. It's probably worth trying on your patient. And you can always call those hotlines. That warm line is really great to get an expert on the phone to talk it through with you for that unique patient. The vast majority of patients do not need doses that high. But if you're, for example, this question is about managing pain, those are great patients to call that warm line and get their support, talk through that specific case and figure out what might work for that patient. It's an awesome resource for you. And thankfully, for the vast majority of our clinicians on the webinar aren't going to be seeing something that complicated. But if you're ever stuck, I would call that warm line. All right. And if you are missing answers to your questions or there's more you wanted to know, info@cabridge.org. No preference for buprenorphine versus bup with naloxone. It's just a diversion thing, but they work the same. Okie dokie. Oh my gosh, you guys are so engaging. I feel so bad that I missed all these. Let's keep going. Awesome. Oh yeah, all our people in rural areas. if you need even more support with follow-up ideas and stuff, reach out to us. How do you get around insurance barriers for higher doses outpatient? Barbara, that's such a good question. If you're having a specific insurer that you're getting issues with, let us know. If you include the ICD-10 code, I think it's F11.9, it's on our quick start guide. If you include the ICD-10 code in your prescription, making it clear what that medication is for, we tend to get less pushback. So I recommend in your notes to the pharmacy on that e-prescribing, write the actual ICD-10 code straight off the quick start guide. Don't have to memorize it. It's right there for you. You can copy it over. That tends to help people not get pushback. People who use methamphetamines, buprenorphine does not treat methamphetamine use disorder, but if somebody uses methamphetamines and fentanyl, you still could start them on buprenorphine for the opioid part. We have a lecture on our website that goes over the evidence that we know so far about methamphetamine treatment, which is different. Unfortunately, not as slam dunk and not as solid evidence, but there are some things you can try. Mirtazapine is one of them. But you can still use bup for the opioid use disorder, but it's not going to help with methamphetamine cravings and dependence. Did you mention giving fentanyl? Yes. So if you have a patient that you are giving buprenorphine, and they're in acute pain, say, or you're not getting through the withdrawal with enough buprenorphine, you're at very high doses of bup, you can add a full agonist on top of it. I would call that your last step, but it's still a step. So as long as don't take the bup out of their system, don't give up on bup and switch to fentanyl inpatient, right? Leave the bup there, but you can use full agonist opioids on top of that to control pain or to help treat if they're really in that severe of a withdrawal picture that you're hitting into the 50s or 60s in the milligrams of your buprenorphine dosing and they're still really sick. You may end up, you tried ketamine, you tried some lorazepam on top of that. You tried clonidine. Don't forget, clonidine is a great medicine. We used to use it. It was the only medicine we thought we had for withdrawal. Don't forget about clonidine. You've tried all of those things. You can then, after that, just give a full agonist, kind of take them out of this acute moment. The bup will stay in their system, right? And then they can get admitted to the hospital and even it out. Or if they're in acute pain, you keep the buprenorphine in there as their base drug, and they can have full agonist opioids as their breakthrough pain medication. It might require higher doses than you're used to. Like we're talking, 2 of morphine is probably not going to do it. You're probably talking about at least 2 of Dilaudid, for example, of hydromorphone. But you can give it on top of it. The key is just leave the bup in the system, right? Don't take it out of their system. Bup for chronic pain. Bup for chronic pain is a different question. So patients who are opioid naive don't belong on buprenorphine, right? So it's not a good acute pain medicine for patients who are new to opioids. But if somebody is in chronic pain therapy, there's a lot of great ways to use buprenorphine, and they do have injectable versions and they have patch versions and stuff like that. It's a great chronic pain medication, to be honest. We are seeing more and more outpatient pain management clinics switch to buprenorphine from things like methadone or oral hydromorphone. It's kind of beyond the scope of what we're talking about today, but I would not be shocked if you start to see more patients on that medicine from their pain management doctors. We do have multiple recorded lectures about precipitated withdrawal and complex withdrawal that were in our Emerging Trends series on the YouTube channel that we have. If you want more information, email us info@cabridge.org. We'll send you the link to that exact video that you're looking for. Our patient was exploding in the bed in the ED. Yeah, we've been there. A lot of us have been there. And we have a full half an hour discussion of complex cases that we could send you to give you some advice. And that's all she wrote. All the questions, so many questions. Thank you all for being here. If you didn't get what you needed, info@cabridge.org. If you want these slides, info@cabridge.org. There's a theme. Email us. We're here for you. Thanks for spending time with us. We hope that this was helpful, and we'll see you next time.